You're listening to Medscape's In Discussion series on lung cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jacob Sands, instructor of medicine at Harvard Medical School and physician at the Thoracic Oncology Program at the Dana-Farber Cancer Institute in Boston, Massachusetts. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Jacob Sands, a thoracic medical oncologist at the Dana-Farber Cancer Institute and co-lead of a committee that helps to run the lung screening program at the Brigham and Women's Hospital. Welcome to Medscape's In Discussion series on lung cancer. Today we'll be discussing lung cancer screening. First, let me introduce my guest. Dr. Shawn Regis is a PhD and the Director of Analytics and Clinical Quality Assurance for Think Health and the Secretary for the Rescue Lung Society. Prior to his current role, Shawn spent 8 years as an associate research scientist and patient navigator for the CT lung screening program at Leahy Hospital and Medical Center in Burlington, Massachusetts, where he managed a program that performed more than 24,000 scans on more than 7,200 individuals. He is a co-author of the ALA ATS Lung Screening Implementation Guide and the Massachusetts statewide 2017 to 2021 Cancer Plan, a panelist on a Thoracic Oncology Perspective series providing practical guidance about lung cancer screening, and was an advisory committee member for an Association of Community Cancer Centers initiative to develop an optimal care coordination model for lung cancer patients with Medicaid. Shawn is a co-author on 20-plus manuscripts pertaining to CT lung screening and has presented across the country and internationally on various CT lung screening topics. Certainly an expert in the field. Welcome to In Discussion.
Thanks so much. Thanks for having me.
So before we kick off on lung screening, I just want to first ask, what is it that drew you into the field? How has your journey been to this space?
So I got lucky to get into the lung screening space. We had a family friend who was a radiologist at Leahy at the time that they were starting their program there and actually worked with Brady McKee on developing lung rads. And he notified me about an opening in coordinating that program. And that was the first I had ever heard about lung screening. And I mean, once you hear about it, I don't know how you can't be interested in it. So I kind of dove right in and saw a whole bunch of opportunities for research and improvement and getting it out there to as many people as possible. So I really lucked out, but I'm certainly glad that I did.
And when was that? When was your first jump into the space?
I got into that program in May of 2014.
So to kick us off, there have been a lot of studies in lung screening, some prior to that, but mostly after the time that you jumped into the space. Let's start off with just a review of the data and what have we seen from lung screening from the data out there so far?
Yeah, so the big one was the National Lung Screening Trial. The results for that came out in 2011. And that's what was really the driving force behind getting clinical lung screening started in the United States. The first USPSTF recommendation, first CMS, NCD were all really just based off of those results. So there's no understating its importance, but at the same time, it's not really what's done in clinical practice. And so a lot has been done since then to try to expand that coverage and make it a little bit more closely resembling what happens in clinical practice as opposed to what was done in that research trial. So since then, we've had the Nelson study and the MILE trial, which have both continued to show a mortality benefit for lung screening. They actually show a greater mortality benefit for a few reasons, one of which being they compare CT lung screening to nothing, which is really kind of what the standard of care was for lung screening, as opposed to the NLST, which compared it to a chest X-ray and still saw a mortality benefit. And the other is they had the age a little bit lower, the pack years were a little bit lower in those trials, and they also screened for longer, which obviously you're going to see a greater benefit as you screen for a longer period of time. So that increased benefit led to the new USPSTF recommendation and CMS decision. So now we've expanded that population and hopefully we can continue to get people in and get them screened.
Yeah, amongst those, there's the NLST and the Nelson trial, which of course are the two biggest studies, the NLST being more than 50,000 patients. And they both have a really similar table, which I always show the residents and fellows around lung screening. So NLST showing a 20% lung cancer specific mortality benefit, and that led to early stopping of the study. Of course, it also showed an all-cause mortality benefit. But table 5 in the NLST, and there's a similar table in Nelson, essentially show that a screen detected lung cancer ends up being around 70% early stage versus the group that got randomized to the CT screening group, but ends up getting a lung cancer diagnosis in the follow-up years within the NLST, or between years even within Nelson. So randomized to get a CAT scan and got a lung cancer, but it wasn't on a screening year. And that ends up being 70% late stage. So even within these trials, we see a really significant shift in the cancer diagnoses, which I think really speaks to the importance of yearly scans. But you've had experience managing a huge program. And so can you talk a bit about the difference between that baseline year, the first year of getting the scan, versus the later years and what you see as far as stage?
Yeah, and that's another reason that the Nelson study and the MILD as well showed such an increased benefit over the NLST, is that they screened for longer. It's the annual scans, like you mentioned, every single year, where you really see the most benefit from lung screening. So at baseline, like you mentioned, we at Leahy saw about 70 to 80% were early stage. But even in those baseline patients, you have some that are real close to presenting with symptoms. You're still kind of finding some bulky disease in there. Whereas if they're an annual screening, they've already had that baseline scan. So that bulkier disease has kind of been moved out mostly. And so in the annual rounds of screening, we see closer to 80 to 90% that are early stage. So getting patients in is a big deal, but keeping them in is also a big deal, because that's really where the benefit comes in, is in those annual rounds of screening.
And in those follow-up years, what is the stage breakdown? Just kind of generally speaking, what's your experience been as far as the stage in those following years?
So we're talking between 70 and 80% are stage 1. And then there's around 10% or so that are the stage 2 cases. And then later stage is another, 10, maybe 15%. But for the most part, we're talking early stage all the time in those annual screens. So it's big.
Yeah, and that's such an important point. I mean, basically, the point that makes is that the screening data we have that led to lung screening implementation, that the real world of being in yearly scanning actually is even better than the data that we're seeing. Can you speak to that? I mean, to what degree do you think that's true? And what do you think the real world data looks like compared to what we've described in NLST and Nelson?
Yeah, it's almost hard to put it into words if you don't, have a clinical program, or at least have an idea of what the data looks like clinically. Because even when people are really trying to promote lung screening, we hear a 20% mortality benefit from the NLST, which is big. That's a big deal. But it's also kind of hard to picture exactly what that means. And it's an undershot, because that we're doing things differently now than we did in the NLST. So as you mentioned, even in between rounds, but really in the absence of screening, we're talking, 70% late stage disease, which that's why it's such a problem. The NLST completely flipped, 70% early stage. So already that's a massive difference. And then we've improved on that by doing annual screening with a better positive predictive value. And I mean, the benefits it's unreal. If you look at some of the numbers that the ALA has given, which estimates about 48,000 lives could be saved every year if all the eligible people for lung screening got screened, that saves more lives than curing breast cancer.
I agree. I think the true benefit of lung screening is actually understated from these studies. So we're saying that the benefit is really substantial. What are the risks of lung screening?
Well, if the benefits are understated, then the risks are overstated a bit. The one that always kind of jumps out at me, because it's just kind of repeated over and over again, is that it has a high false positive rate. And there are a couple issues with that. One is, if you're hearing that it has a 96% false positive rate, that's not the false positive rate. That's the number of positive scans that end up not having cancer, which is different. In the NLST, the false positive rate was really closer to 23, 25%, somewhere in that range, which is elevated and not terrific. But again, that's not what we do clinically. The NLST had a lower threshold for what they were calling positive. In clinical practice, with a 6 millimeter threshold on nodule size, false positive rates in the 8 to 12% range. And if you do things the way the Nelson trial did it, where you need a follow-up scan before you actually determine if something is positive or not, it's down to 2% for a false positive rate. So it's very comparable to what you see in mammo, and it's not a high false positive rate at all.
Yeah, I think that's been actually one of the most confusing things, particularly for primary care, where they're seeing different headlines and such. But I want to pause for a moment and kind of really focus in on something you said there. The Nelson trial suggests that the false positive rate is much better when using their strategy. Of course, they essentially don't call something positive, but say indeterminate, and then you need to do another scan at whatever the recommended time point is, whether that be 3 months, 6 months, essentially doing that scan. And then if the nodule is growing, is then labeling it as positive, versus in the ACR lung rads, calling something positive, even if it's something that you're then going to do a scan in a few months to determine. So it's a different format, which you outlined a bit. But you also have published data from within the Leahy program. What does that look like as far as your false positive rates and your detection rates?
Yeah, so what we did at Leahy was to consider a lung RADS 3 or higher to be positive. Now, a lung RADS 3 is considered probably benign, but it does require something other than the patient just coming back in a year. So that's what we call positive. And what we found is that really the cancer detection rate in that group is only between 1% to 2%, probably. So if we waited to call those positive until after that 6-month scan, you would see our false positive rate drop way off as well. But even including that group as positive, it's about baseline, I think it's around 12% false positive rate. And then annually after that, it's more like 8%. Because again, now you have a comparison and you can see that if there is growth or not, and that kind of bumps off a whole bunch of those false positives that you were seeing before.
And what about the cancer detection rate?
So on baseline, it's about 2% at Leahy, and then annually, every single year thereafter, it's about 1%. So that kind of goes to your point about doing this every year. There's been talk about, do we do it biannually, or if they're, a lung RADS 1, should they be pushed out? It's 1% every single year that we see consistently in that program. And so I think it's a big deal to make sure that they're coming back every single year, because that's where you find these cancers and get that benefit.
Yeah, in the US, it's approved to be done yearly, and that is the recommendation. That's the USPSTF guidelines. In other countries around the globe, they're deciding how to run their screening programs, and there's been some debate about that. One of the things that did not come out in the Nelson publication, but I do remember being presented at World Lung, at the IASLC World Conference on Lung Cancer, was that when there was a 2.5-year time frame between scans, they actually had an increased number of late-stage diagnoses. Now, I don't remember whether they actually did a statistical analysis of that, so I can't say it was significant, but it was substantial. It was certainly a numerically clear difference within those. And I do worry about the time frame being more than a year between scans based upon that, and that really substantial stage shift that we discussed in the very beginning that we see in both the NLST and in the Nelson study. So I agree. The confusion around false positives certainly is out there. Are there any other risks that you think are important to highlight?
One of the other big ones is the radiation dose, which I think is what contributes a lot to that conversation about should we not do this annually, because that's a lot of CT scans. And it's just important to point out that these are low dose CTs, and again, even lower than what was done in the NLST. The amount of radiation that was being used at Leahy for these was almost the same as what you see in a mammogram. So if there's no problem with doing that annually, there's really no problem with doing this annually. Concerns about additional workup for those positive findings that don't end up being lung cancer. But there are several publications out there that show that the rates of intervention on benign disease for lung screening are real low, especially if you have multidisciplinary involvement and you're discussing these cases and what should the next steps be. It's always a risk that you're going to intervene somewhere that's not cancer, but if you're not intervening enough, then you're missing some. So, you got to kind of weigh that out and make sure that you're doing everything you can to find and take care of these cancers. And the last is the overdiagnosis, where people are concerned that, you're diagnosing lung cancer that isn't really going to affect anybody in their lifetime. But that hasn't really panned out either. The NLST in a follow-up study showed that that's about 3% for lung cancer. So again, it seems the benefit significantly outweighs the risk. And so it's just important to have all those things in mind when we're talking about these with eligible patients.
Yeah, these are such important points. Just to add to that, that the NLST follow-up you're describing, the initial publication suggested that there may be a big overdiagnosis just because of the incidence of cancer detection between the two groups. But as you highlight in further follow-up, the incidence of cancer between the two groups really became, I think it was like a 20-person difference in the follow-up time frame, essentially showing that those that were in the chest x-ray arm, so not getting CT scan, they had decreased numbers of lung cancer in the initial publication, that in follow-up years essentially had more people diagnosed with a lung cancer during those follow-up years, that essentially brought those numbers pretty approximate. Just to put some numbers on what you said about the radiation dose, I've heard Andrea McKee, radiation oncologist, obviously at the Leahy program as well, talk about the fact that in radiation oncology and radiology, the box that they wear, they can get up to 50 millisieverts per year of radiation exposure, and that's still considered occupationally safe. And a lung screening scan is less than a millisievert. So it's less than 1/50th of what our colleagues can get and still considered to be safe. But the other topic you brought up, that people getting a procedure and not having a lung cancer diagnosis, I mean, this is a tough one because obviously we want that to be 0%. But you did highlight the challenge of this and the balance of the number of lives that you're saving by doing the scan and by intervening versus potentially leaving a cancer there. That seems to be a challenging one. Can you talk to within the Leahy system or even beyond, what is the best way of addressing that?
Yeah, so the main difference between lung screening and mammography in this case is what we're doing with those positive findings. So in mammo, it's pretty straightforward where if you see something, you're going to get some tissue because it's really hard to do a ton of damage with a breast biopsy, but you can't be doing that with lungs, just, sticking a needle in everything that looks like it might be a problem. So one of the bigger things is growth for lung cancer screening of whatever you're seeing in there. And so the vast majority of follow-up is just imaging. It's just imaging that's happening less than a year later, as opposed to those who are in the annual screening. If it looks stable or if it goes away in that time, then you don't have to worry about anything. If it's growing or it still seems concerning for whatever reason, now we're talking about advanced imaging like a PET scan or tissue sampling. But again, the way that we managed that at Leahy was basically everybody was going through a pulmonary specialist. So you have somebody who's making those decisions that has not only just the imaging to look at, but clinical expertise and an idea of the patient's individual situation in terms of what are the best next steps. That's really all you can ask for. We never did anything based off of, okay, this lung screening exam shows this, so you need a biopsy. It was always somebody had to see a specialist first who was going to take everything into account before those kinds of decisions got made. And you see that the numbers are real low when it comes to benign disease interventions, just by involving those specialists and making sure that they have a say in what happens with the patient moving forward.
Yeah, and your group has published the very low numbers of intervention for non-lung cancer. Now, we've covered the very substantial benefits and pretty limited risk. That being said, the American Lung Association releases a state of lung cancer report each year. They highlighted that the state that you've done your work in is Massachusetts, and it leads the country at only 18% of people who qualify getting screened. So really every state is failing, but Massachusetts leads at 18%. Why do you think the numbers are so low?
There's a few reasons. And the first one, which often gets overlooked, but is worth pointing out, is this is still kind of new. A lot of the other screening modalities were low for a while too, and they didn't have one of the second problems, which is the stigma that's associated with lung cancer and smoking that has existed for quite a while and makes it easy for people to be not so supportive of lung screening and trying to find lung cancer in these patients. A lot of it is that this is largely something that your PCP would be recommending, like mammography, only less well known. And until this most recent USPSTF recommendation, the Society for Physicians, the AAFP, wasn't supporting it. And so that makes it difficult to convince your primary cares when they have all of this other stuff that they need to talk about, that lung screening should be at the top of the list. And really it should. I'm hoping that we've turned that corner a bit. the conversation about risk to benefit ratio should be done. It's got more randomized control trials than any other screening modality. Now we're at the point of, all right, we got to spread the word. We got to get more facilities doing this and doing this correctly. And we just got to screen patients. Let's get them in and get them screened because we know what this can do when we do that.
Now, all that being said, the program that you were running really had a screening rate that was much higher. So how did you get there? What were the important cornerstones to building a really optimized screening program?
The two big things that I always preach, which are usually also the hardest to get, are a dedicated patient navigator, not somebody who was doing something else that now you're going to pull in to manage the lung screening program as well, because it's a massive undertaking and it can't be just kind of something that you're doing on the side. And then some sort of program management system that's going to help you track all of these patients, because as much as I love Excel, it's really hard to manage a lung screening program doing that. But a lot of places are reluctant to dish out the money for those resources. And a lot of that goes back to what we've talked about with the misinformation that's out there and the stigma surrounding the disease, that it's not at the top of their list for them to support, and it needs to be. Leahy was lucky to have Brady and Andrea McKee, who are very vocal and very persuasive. They talked to the primary care groups and got them to refer patients in. There were community events where we talked to the patients to explain what lung screening was to them and get them directly involved. So I think the biggest thing is appropriate education. The shared decision-making aid that's in the JTO has a lot of the appropriate information in it. All the other stuff used to be based off the NLST. And like we've pointed out a few times, as important as that study was, it isn't really relevant in terms of numbers anymore because it's not the way things are done clinically. And so it's important to have the right information. And that, I think, is what is going to get people to, finally come to the right side.
Yeah, that shared decision aid in the JTO from 2021, as you mentioned, that is really made to help primary care doctors with that discussion with patients, to be able to have a very rapid discussion with patients as to the risk and benefit of lung screening that hopefully really assists in those discussions. Before we wrap up, where are some places that people can go who are trying to build their programs or optimize their programs? What kind of resources are out there?
Yeah, so there's a lot of good places to go. There is the ALA ATS implementation guide is out there, which has some input from a bunch of different screening programs on how they do things, how they did things to get where they are. The Rescue Lung Society website has a lot of information about how to build a program. And again, a lot of the answers to the questions that you may have as you're going through this process. The ALA is a good resource. The GoTo Foundation has a lot of good resources. There are a lot of places where you can go to get good information on how to help build your program, get patients in, and really run an effective program.
Well, to wrap things up, we've covered quite a bit today. So we've discussed the risks and benefits of lung screening, essentially highlighting the NLST and the Nelson studies, which really showed that the benefits of lung screening that led to ultimate USPSTF recommendation and then updates of increasing the population that qualifies, while also highlighting the fact that the true benefit of lung screening is probably more than what we even see in those studies. The risks of lung screening, as Dr. Regis said, are likely overstated. We essentially highlighted that radiation itself is pretty minimal and not really considered a substantial risk. That the false positive rate has really been, unfortunately, misstated, and that the false positive rate is really quite a bit lower than what has been out there. I think you had said within the Leahy program, it's around 12% in that first scan, but only about 5% in follow-up scans. And in most cases, it's just a follow-up CT scan and not intervention that highlights the fact that ultimately it ends up being negative. And that the risk of intervention is actually quite low, but is an ongoing area of effort and something that we want to get to 0% in people who do not have a lung cancer diagnosis. We've highlighted the pillars, essentially, of a lung screening program, being having a navigator, having a multidisciplinary group, and working with primary care to really optimize their ability to order scans and counsel patients on that, as well as the JTO publication that has a shared decision aid that primary care can utilize in their discussions. And then the American Lung Association and ATS Lung Screening Implementation Guide is an excellent resource for a lot more information. Websites like therescuelung.org also have some information on those as well. And with all of that, Dr. Regis, thank you so much for joining me today for this important discussion.
Thanks so much for having me. I appreciate it.
And thank you to all of you tuning in. This is Dr. Jacob Sands for In Discussion.
Thanks for listening to Medscape's In Discussion Lung Cancer podcast series with our host, Dr. Jacob Sands. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on lung cancer.